Ladies and gentlemen, dear colleagues, let me present you my 6-month progress report, my PhD topic, Prognostic Factors of Serum Biomarkers in Urothelial Cancers. My name is Ádám Széles. I'm a part-time resident and PhD student here in the Department of Urology in Semmelweis Clinic. My vision is therapy optimization in immune checkpoint inhibitor usage, and as a mission I would like to assess the utilization of different biomarkers in urological cancers treated with immune checkpoint inhibitors. It's just a quick view of my 3 ongoing projects, so please let me go one by one. My first meta-analysis name is investigating the prognostic significance of soluble PD-L1 and soluble PD-1 in human malignancies treated with immune checkpoint inhibitors. About the background, I think it's out of any question that cancer is one of the most important life burden in today's life, and immune checkpoint inhibitors are a prosperous drug to treat cancers. And how hot topic is this? You can see a drawing of 2 gentlemen who earned the Nobel Prize in 2018 for their discovery of immune checkpoint inhibitors. So how these drugs work, you can see here cancer cells and the T cells, they both expressing PD-L1 and PD-1, and if these 2 receptors bind together, that causes an immune suppression. So if you block it with an agent, immune checkpoint inhibitor, that causes an immune boost, so the T cells will more likely to kill cancer cells. This sounds really promising, but what we can see in the reality is that immune checkpoint inhibitors are really effective, but for a small amount of patients. My clinical question is that does these 2 biomarkers have a clear, well-defined prognostic value in human malignancies treated with immune checkpoint inhibitor? And if we construct a PICO framework that will look like this when we have a population of all kinds of cancer who receive this therapy, and we, as an exposure and the comparator, we are comparing the high and the low concentration of these biomarkers, and the outcomes we choose overall survival and progression-free survival. We did the systematic search in these 4 databases with the following search key, and we found 458 articles, and when we did the selection process, we found 13 potentially eligible articles. And about the results, here the biomarker is soluble PD-L1 and the outcome is overall survival, which is one of the most important cancer-specific outcomes. And you can see the subgrouping based on the type of cancers. And what you can see that the heterogeneity is quite high, but this comes from that we are comparing different kind of cancers, and these cancers in a different stage, and the population size is quite different within these studies. So what are the numbers mean? We are talking about hazard ratio. If the hazard ratio is less than 1, that means that patients with high biomarker levels have a better survival, meaning that this biomarker is a protective factor. And if the hazard ratio is more than 1, then this biomarker is a risk factor, meaning that these patients have worse survival rates. And if you look at, for example, in the melanoma and in the non-small cell lung cancer group, this hazard ratio are quite opposite. So what this overall 1.42 hazard ratio means, that this means that patients with high soluble PD-L1 level have 42% more likely to have worse survival rates during immune checkpoint inhibitor therapy. The next result is progression-free survival. This is also really important in cancer-specific studies with the same subgrouping as I mentioned before, and we have the same heterogeneity problem that I also described before. And here what we can see that this 1.05, meaning that patients with high soluble PD-L1 level 5% more likely to progress during this disease. What happened here that we had more articles where this high biomarker was a protective factor and less articles when this biomarker was a risk factor. What are the strengths of these studies? That this will be the first meta-analysis that's investigating this soluble PD-L1 in an aspect of immune checkpoint inhibitor usage, and we have a significant number of articles compared to previous meta-analysis when there were no restriction to therapy. The limitations of these studies is, as I mentioned before, the heterogeneity, and it can be a limitation and the strength that we are working with half retrospective and half prospective studies. Certain limitation is that the cutoff values where they draw the line between the high and the low level of the biomarker is quite different within these studies, and they used different ELISA kits. About the conclusion, in different cancers we saw that serum PD-L1 have a different role, so this will indicate that serum PD-L1 might have a cancer-specific prognostic value. The implication for research is to encourage researchers and pharmaceutical companies to invest more money and time in biomarker-based randomized control trials, and for implication for the practice will be to use prognostic and predictive biomarkers for therapy optimization. My next meta-analysis is a really similar prognostic type of study, but this time I will investigate the prognostic significance of neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, CRP and LDH, but this time in urothelial cancers, but again treated with immune checkpoint inhibitors. Again, about the background that bladder cancer is among the top 10 most prevalent cancers in the world, and unfortunately metastatic bladder cancer's 5-year survival rate is only 5%. And at that time when we have metastases, we have to give some kind of systemic agent. We either have platinum-based chemotherapy and immune checkpoint inhibitors. So the aim of this study to highlight the importance of widely accessible laboratory markers in clinical decision-making. The clinical question is again very similar, and if we construct a PICO framework that's again really similar, and the implication is to use these parameters to help in therapy optimization. In the couple of weeks, in the next week we'll do the systematic search. The third study name is the prognostic significance of soluble PD-L1 in upper tract urothelial carcinoma. This will be a retrospective cohort analysis. About the background, UTUC, upper tract urothelial carcinoma, is a rare disease. It's only 5 to 10% of all urothelial carcinoma. And when we're talking about therapy, we either have surgery, radical ureteronephrectomy, and because this is a urothelial carcinoma as well, we have platinum-based chemotherapy and immune checkpoint inhibitors as well. But you can see in the picture that in an early stage, this cancer can block the flow of the urine that can result in a kidney damage. And cisplatin, which is the most effective type of platina, is kidney toxic. So you can imagine if you want to give a kidney toxic agent to a previously lowered kidney function, it's maybe not the best options. So that is why I would like to highlight to find immune checkpoint inhibitor eligible patients is even more important within these kind of cancers. This is our cohort. We have 65 patients, which sounds a bit low, but this is a rare disease. And we have 34 patients in the surgery group, 25 patients in the chemotherapy group, and 6 patients in the immune checkpoint inhibitor group. We did the analysis with sandwich ELISA, and I can show you some result that this is the surgery, and in the chemotherapy group you can see Kaplan-Meier curves of overall survival, and in both groups the green line is the patients with high biomarker level, and the patient and the blue line is patients with low biomarker level, and in both groups you can see significant result that patients with high biomarker level have worse survival rates. Other important comparisons will be in this study the age, sex, ECOG status, kidney function, grading, staging, metastases, and because we have post or on treatment levels of this biomarker, we would also like to investigate the follow-up. just a quick view of my 3 ongoing studies. And I would like to thank you for your kind attention with the word of water that I disapprove of what you say, but I will defend to the death your right to say it. Thank you very much.
Very nice presentation, congratulations. Could you go back to your first plot, please?
First plot?
The first plot, yes, if it's possible. Because based on your results, as far as I can see, so this checkpoint inhibitors can be either a risk factor and a protective factor.
No, the biomarker.
The biomarker,
yes.
Okay, thank you. So did you check the literature? What can be the reason? Because in the different subgroups, actually, you can see different results. And what can be the reason if you check that? Patients
who received immune checkpoint inhibitor and investigated their soluble PD-L1 biomarker is almost, this is all the articles what we have. And this is really interesting because what we want to maybe implicate that this biomarker is not just prognostic, it may be predictive. But to assess the prediction to a biomarker that this is predictive, meaning that it can predict what kind of therapy should we use. For example, if this biomarker is high, we should give immune checkpoint inhibitor, but this is low, we shouldn't give this. We would need interventional kind of studies. That is what was one of the implications that encourage researchers to do biomarker-based randomized controlled trials. So unfortunately, we have observational studies, and this is what we observed. That in some cancer, this is protective, and in other cancers, this is a risk factor.
Okay, thank you.
That's not enough, so say something more about this. That is there any kind of pathophysiological background of this that which indicate, I mean not indicate actually, explain this? I mean in some cases this is protective, in other cases it is not. Probably this is, I mean, a multifactorial regulation, and in different cancers, I mean some pathways are actually spread, but you say.
As in my knowledge, I don't know exact pathological ways that why this is happening. Why we are doing this is that this is the 2 receptor where this drug works. And what we can see in that when we measure the tissue level of this biomarker, so PD-L1, not in the serum or in the blood, but in the cancer surface, it is a predictive factor that somebody who has a higher level of tissue expression, they give immune checkpoint inhibitors. Yeah. So that is what we try to see if the soluble version of this have the same result.
Yeah, but you must understand the molecular events behind, because you also plan a study, I mean a kind of your own trial or whatever, and then to understand what is really going on. I mean, that's important to understand that part too, not only to take it as a kind of something which is coming out of the cloud, but there must be some explanations for this, and this could be actually quite important, because there might be some other points which actually work together with this, and then you can interfere them in the next step.
Yes, there is, for example, there is also a biomarker called the MMP7, which, for example, cleaves this PD-L1 and then goes into the plasma. And our laboratory is also doing a study within this biomarker as well. So it's a complex field.